I think one of the big stories of 2023, talking about healthcare, is we're going to see rural hospitals closing down. And I wanted to talk it over today with my healthcare expert, Paul Seegert, because an article really caught my attention over the weekend. It's in a publication called Becker's Hospital Review, and a medical center in South Carolina is filling an empty wing of its hospital with 36 prison inmates in an attempt to stave off closure. That's how bad it's getting. What is the reason for this? Is the problem fixable? Here is Paul Seegert from PCS Advisors. Paul, welcome back to Iowa Radio. Good morning.
Thanks for having me, Jeff. Good morning.
So what's at the heart of this, Paul? Obviously, as you might imagine, it's a huge story in Iowa, rural Iowa, hospitals really struggling to stay afloat. What's the issue here?
Well, the big picture is that rural facilities especially have to survive on customers who are getting their coverage from Medicaid, Medicare, or are uninsured. And the system has been propped up by commercial paying plans. The hospitals generally lose money on those programs. When someone shows up and that's how they're going to pay for care, they may not realize it, but the government is not reimbursing the facility enough in many cases to cover the cost of their procedures. And that worked historically because you had so many more of us that got our health care at work, but that has been a long-term decline. 1999, 67% of us got our coverage at work. Today, we're down below 50%, 49% of us do. So it's put us in a very, I think, unsustainable situation and position. You've got 74 rural facilities that closed in the first decade of the 2000s, and then in the next decade leading up to the pandemic, 136 closed in 2019. So it's a real problem, and it's because the government, quite frankly, isn't reimbursing them for at least the cost of care, never mind some profit margin.
Right. And Paul, I mean, it's easy to say, well, the solution to this is the government should reimburse them more, but we're already dealing with a massive federal deficit, and I'm sure that's what everybody's keeping in mind as they try to figure out what to pay hospitals. Is there a solution to this?
Oh, I think there is. There's a couple things have to occur. One is we need more transparency in the system, and we need to get some free market forces involved, and that will allow these facilities to compete. You've got the insurance payment model that also treats these rural facilities with less bargaining power more aggressively and reimburses them less. And then you also have a lot of waste in the system. You know, when we spend money on healthcare, we're spending, I think it's fair to say in our work, it's very common that we're spending $1.50 when we could be spending $1, sometimes $2 when we could be spending $1 on healthcare in this country because of waste that's in the system. Now, hospitals, it's not just hospitals I'm talking about, and by the way, 53% of our hospitals are going to post a loss this year because of their increasing costs and inflation and all the other factors. So they're not the enemy, but we need transparency if we're ever going to get this fixed. And once we see the waste across all the different cost drivers, drugs probably being the biggest offender, we can get the funds going in the direction that they need to in this fifth of our economy. But we don't have free market forces largely in the way that we pay for health care. Most of us have no idea what something actually costs. We just know what our copay is.
Well, and Paul, as you pointed out earlier, part of the problem is less and less employers, employer-covered health insurance, right. And that's a trend that's going to continue, isn't it, Paul? What's driving that trend?
It will continue because you have this perfect storm where facilities need to charge employer plans more to make up for the lack of reimbursement they're getting, say, from a government-provided plan, and then more people move over to a government-provided plan because premiums go up for employers. So more and more small employers continue to get priced out and say, to heck with it, I'll just give my folks a raise, stop offering this plan because what I can afford to offer it has become such a high deductible plan that they're functionally uninsured anyway. They might as well just go to the exchange with everybody else.
Yeah.
And it makes sense at that individual employer level perhaps to do that, but it's part of this overall big picture problem that we're creating.
Right. And Paul, to be honest, and I know you track these things, I'm looking at the Republicans taking over the U.S. House and what their priorities are going to be. This doesn't seem to be one of them. I'm not sure Congress, regardless of the political party, is willing to address this anytime soon, are they?
I don't think so. It gets characterized as attacking programs, attacking the retired and so on, which it really shouldn't be. It should be possible, and it frankly is very possible, that we can improve the quality of care and reduce costs. That is possible. All the evidence you need is to look at examples in our healthcare system where the insurance payment model is not involved. Look at LASIK, look at elective procedures, look at somebody that gets a cosmetic procedure. Over time, the quality goes up and the costs go down because it behaves more like other parts of our economy. We don't have that here in the insurance payment model because there's just no transparency to allow it to happen.
But and how would that work though, Paul? Because the thing is, people say, "Oh, it sounds like a good idea," but is there a realistic system you can create where I really can pick and choose who can offer me services based on price? Like
absolutely.
Is there?
Yeah, absolutely. We're doing it one employer at a time every day. It's not easy to do. It's a slow process to do it one employer plan at a time, but you can build systems in a health plan where consumers have access to quality and cost information at the time that they need it in a similar way to what they're able to access with anything else if they're going to buy a TV or plan a vacation. And in healthcare, it might be that they have to talk to an advocate, a nurse or somebody who can guide them through the system. But I was looking at an employer in Dallas, and you had 10 locations. You can get an MRI within 25 miles, all in network with Blue Cross Blue Shield of Texas. One would charge a health plan $700. The high-cost facility would charge the health plan $7,000. The consumer has no idea.
Right.
All they know is my health plan says it's $100. Well, that shouldn't be allowed to occur that way. What we should do, and what we're doing one employer at a time, is creating a situation where the consumer can know the total cost and get rewarded if they choose to go to a more competitive facility for that procedure, not just based on cost, but quality. Ironically, cost is inverse to quality in many cases in our system today. So it actually benefits them from a quality standpoint, too.
Amazing. That is Paul Seegert. He is from PCS Advisors. That is a health benefits consulting firm, and you can tell, really like talking these issues over with Paul. Thanks very much, Paul, for joining me this morning.